Hello, my name is Islam Shireen. I'm Assistant Professor of Ophthalmology in the Faculty of Medicine of Alexandria University, Egypt. In the next few minutes, I'll be talking to you about the idiopathic intracranial hypertension from the ophthalmological point of view. I'll try to focus on the terms that we use in ophthalmology and you may see in our reports. It's important to know about these terms to understand how we think. So first of all, let's agree on the definition of the idiopathic intracranial hypertension, which means increased intracranial pressure with no identifiable causes. As the name implicates, it's idiopathic. There are symptoms of raised intracranial pressure like headaches and visual disturbances, and there are some signs. Papilledema is the most important one of them. The disease is more common in women in the reproductive age group, and it's also more common in patients with increased body mass index, that's to say overweight. In pediatric group, it's reported to be occurring in 0.5 to 2.5 per 100,000 patients per year. The modified Dandy criteria gives a more solid diagnosis of the idiopathic intracranial hypertension. These criteria include signs and symptoms of increased intracranial pressure with no localizing neurological signs, except one thing that we will know later in the presentation. There is elevated CSF pressure. The opening pressure should be more than 25 centimeters of water, and there is normal CSF composition. In addition, there is a normal imaging, and the recent studies emphasize the importance of using the modern imaging technologies like MRI and MRV for exclusion of secondary causes of raised intracranial pressure. So those cases should not be included as increased intracranial pressure. This is an MRV of one patient showing a superior sagittal sinus thrombosis, and this is an MRV of another patient showing transverse sinus thrombosis. Again, other causes of raised intracranial pressure should not be considered as idiopathic intracranial hypertension, like cases with obstructive sleep apnea, medical causes like systemic lupus or renal failure, endocrine disorders like Addison's disease, polycystic ovary syndrome, drugs like tetracyclines and steroids. This is a reference about the definition of the idiopathic intracranial hypertension. Now let's move on to discuss the ocular manifestations of the IIH. The symptoms will include headaches and visual disturbance like blurry vision or double vision. The signs will include optic disc swelling, or what we call papilledema, and visual field defects. In several studies, headaches were found to be the most common presenting symptom of the IIH, followed by transient visual obscuration, that's to say disturbance of the vision for a few seconds, and some patients may suffer a long-term visual loss, some patients may suffer diplopia, and notice that some patients may not suffer any symptoms. It's very important from the ophthalmological point of view to talk about papilledema, which indicates bilateral optic disc swelling secondary to increased intracranial pressure. It's the most common ocular manifestation of IIH, occurring in up to 95% of patients. Note that it does not necessarily happen in every patient with IIH. The optic nerve is considered as an extension of the brain. It shares the same dural coverings. The postulated pathophysiology of the papilledema indicates that increased intracranial pressure will be transmitted to the optic nerve head. This will lead to venous engorgement and stasis of the exoplasmic flow, leading to swelling and elevation of the optic disc. When we talk about the grading of the papilledema, we should follow the Friesen classification. The Friesen classification starts with grade 0, that's to say a normal optic disc, in which the borders of the optic disc are very sharply demarcated and they are not elevated, and the cup of the optic disc is not obliterated. It's clearly seen in those two optic discs. In very early papilledema or grade 1, there is minimal C-shape or reversed C-shape elevation of the peripapillary area with a normal retinal nerve fiber layer thickness. In grade 2 papilledema, or what's known as low-grade papilledema, there is elevation of the nasal edge of the optic disc, this part, and there is circumferential halo around the optic disc, and there is retinal nerve fiber thickening. So there is elevation when we look using the indirect ophthalmoscope or the slit lamp. We find that there is elevation of the nerve fiber layer at the optic disc. In grade 3, or what we call the moderate papilledema, there is elevation of the entire disc and there is obscuration of the blood vessels. So the nerve fiber layer will start to swell and it will obscure the vessels as they pass from the optic disc to the retina. As you can see here, we cannot see the details of the blood vessels because they are obscured by the nerve fiber layer. In addition, there is nerve fiber layer thickening, exudates like those white part, and hemorrhages in the peripapillary area. Grade 4 papilledema, or what's known as high-grade papilledema, is characterized by severe optic disc elevation with obliteration of the optic cup, so we can no longer see the optic cup that is normally present in the optic nerve. There is extensive retinal nerve fiber layer thickening, so the disc is severely edematous, and peripapillary changes like the exudates and the hemorrhage. Grade 5 papilledema, or what's known as severe papilledema, is characterized by advanced optic disc swelling and severe visual loss. Those patients will usually pass to the secondary optic atrophy, as we will discuss later. This is a useful reference about the freezing classification of papilledema. Another sign that may happen with papilledema and you need to be familiar with is the visual field defect. Visual field defects are common in idiopathic intracranial hypertension. This can include primarily enlargement of the blind spot. So as the disc starts to swell, the blind spot, which is a non-seeing part of the visual field, becomes progressively larger, like in those cases. By the way, this is called the automated perimetry. This is a machine that measures the visual field and give a quantitative representation of the areas with defects. In addition, there is the nasal field defect, like this one, start to have a problem with the nasal field. Sometimes we have an arcuate visual field defect. This is more common with cases of neglected and long-standing papilledema passing to optic atrophy. These defects can be reversible early in the treatment of the IIH. However, they may become permanent if the patient will pass to secondary optic atrophy. One of the signs that may be present in IIH is the visual loss. This can happen due to optic nerve damage with chronic papilledema, or what we call the secondary optic atrophy. So in cases with long-standing papilledema, they may start to develop this secondary optic atrophy, in which the edema starts to calm down and become less, but the vasculature of the optic disc starts to decrease. The disc starts to become pale, and the blood vessels around the optic discs become sheathed. This indicates that this is an atrophy of the optic nerve that was preceded with papilledema. It's important to differentiate this secondary optic atrophy from other causes of optic atrophy, like primary optic atrophy, which occurs primarily in demyelinating diseases, or compressive optic neuropathy, in which the optic disc again is very pale, but it's very, very well demarcated. The edges of the disc are well demarcated and not blurry like in secondary papilledema. One of the signs that may be seen in patients with IIH, the sixth nerve palsy. For example, this patient has failure of abduction of the left eye due to left abducent paresis or paralysis. Sixth nerve palsy is common as an ocular manifestation of IIH, occurring in about 20% of the patients. It's thought to be a false localizing sign. This is the only localizing sign that may be present in patients with IIH. We talked about that earlier in the lecture. It's thought that the nerve becomes compressed with the raised pressure over the apex of the petrous temporal bone. So it's considered a false and not a true localizing sign. These are some useful references about the ocular manifestations of the IIH. Please remember that we mentioned that 90 to 95% of patients with IIH will present with papilledema. However, there is a subgroup called the occult IIH, which is IIH without papilledema. It's diagnosed via repeated finding of the CSF opening pressure more than 25 centimeters water without papilledema. It's postulated that there is a pre-existing optic atrophy that precludes the occurrence of papilledema in those patients. These are some useful references about the occult IIH. The treatment of the IIH is primarily the job of the neurologist, and I'm not going to go deep in this part. However, the main drugs used for treatment of IIH will include the acetazolamide, known as Diamox or Sidamex in the Egyptian market, the topiramate, and the furosemide and high-dose steroids. The surgical treatment includes CSF shunting procedure to decrease the intracranial pressure and prevent progressive optic nerve damage. In patients in which the intracranial pressure cannot be controlled with shunting procedure, we may resort to a procedure called the optic nerve sheath fenestration, in which we try to make an opening in the dural sheath around the optic nerve to release the pressure and decrease the pressure over the nerve and prevent secondary optic atrophy. There is a progressive increasing evidence about the role of the venous stenting in selected patients. So, we need all to agree that the IIH requires a multidisciplinary approach. The role of the ophthalmologist is important in diagnosis and managing the IIH by monitoring the papilledema and the visual function. And the recent studies emphasize the importance of the evidence-based treatment and advanced imaging techniques. Those are some additional references for those who wants to have some more information. I believe it's important to talk about the idiopathic intracranial hypertension treatment trial. I will discuss that in the next few slides. So it was a multi-central study that studied or evaluated the efficacy of the acetazolamide with low sodium weight-reducing diet against placebo plus diet control in improving the visual function in patients with idiopathic intracranial hypertension. It was a high-quality randomized double-masked placebo-controlled trial. Included 165 participants with mild visual loss due to IIH. Participants were randomized to receive either acetazolamide or placebo, with both groups following low sodium weight-reducing diet. So the primary outcome of the study was the perimetric mean deviation. This means the change in the visual field of the patient from a normal patient with the same gender and age, which is a measurement of the visual field function. The study evaluated the changes in the perimetric mean deviation from baseline during 6 months period. The mean deviation is reported in the perimetry outprint. It represents the deviation of this particular patient from a similar patient with the same gender and age, and it's an indicator of the change of a global indicator of the change of the visual field. So patients with more worsening of the or higher mean deviation, this means that they have worse visual field and worse visual function. The study showed that the patient received acetazolamide showed greater improvement in the perimetric mean deviation compared to placebo group. The mean change in the perimetric mean deviation was minus 0.71 decibel in the acetazolamide group compared to placebo group. This means that the acetazolamide is more effective than placebo in controlling the visual loss due to IIH. The secondary outcomes of the study showed that the weight loss was more in patients with acetazolamide group than the placebo group. The CSF pressure was lower in patients receiving acetazolamide than those receiving placebo. And finally, the visual symptoms improved more in patients receiving acetazolamide. So patients receiving acetazolamide did better in different aspects than those receiving placebo. The study concluded that acetazolamide plus diet control, taking low sodium, weight reducing diet, led to improvement of the visual function in patients with mild visual loss due to IIH. So that study provided evidence about the efficacy of acetazolamide in treating IIH and highlighted the importance of weight loss and diet modification in managing IIH. This is the reference of the study. Now let's move to some ophthalmological inputs that can be done for patients with papilledema due to IIH. So I'll talk in the next few slides about the role of the ocular ultrasound in diagnosing and monitoring papilledema associated with IIH. So the ultrasound is used frequently in the modern ophthalmology practice. It depends on a machine that emits ultrasonic waves. These waves are capable of penetrating the tissues around the eye and the tissues of the eye itself. And when they are reflected from the tissues, the machine will absorb them and will give us a representation of what's going on in this eye. As you can see here, they can give a clear image from the eyelids, cornea, anterior chamber, lens, vitreous, sclera, and the optic nerve. What's important for us in our subject is the optic nerve. So now there is a strong evidence that the optic nerve sheath diameter, which is represented with this part, is increased in patients with papilledema secondary to idiopathic intracranial hypertension. In a meta-analysis of 13 studies, a pooled sensitivity of 90% and specificity of 85% were found for detecting increased intracranial pressure with increasing the optic nerve sheath diameter. In another study, it gave a cut-off point of 5.8 millimeters of the optic nerve sheath diameter. Patients with larger values are believed to have increased intracranial hypertension. The study reported the sensitivity of 88% and the specificity of 73% for detecting papilledema using this method. The advantages of the ultrasound include that it's a non-invasive technique, so there is nothing going inside the eyes. It can be performed quickly, so when the patient is visiting at the clinic, you can do the ultrasound. It's a useful bedside tool if the patient is an inpatient or in the ICU. It can detect optic nerve disc drusen. This is an important item to differentiate from papilledema. It's one of the causes of pseudopapilledema, and it represents with a hyper echogenic structure at the optic nerve head. This is not papilledema. This is one of the differentials. It can be easily detected with ultrasound. The main limitation of the ultrasound that it is operator dependent, so it's affected by the operator expertise and the patient positioning. That's to say, if the probe, for example, is not apposed to the eye properly or not in the proper angle, or if the patient is moving the eye slightly to the right or slightly to the left, this may give false results. In addition, further studies are needed to standardize the optic nerve sheath diameter measurement protocols and establish the clear cutoff values for diagnosing IIH. These are some useful references about the role of the ultrasound in diagnosing IIH. Now let's tackle another point that is important from the ophthalmological point of view, which is the use of the optical coherence tomography in patients with idiopathic intracranial hypertension. This was evaluated in the OCT IIH study. So first of all, we need to understand a simplification of the OCT principle, or the optical coherence tomography. It's very similar to the ultrasound, the ocular ultrasound. However, there are two main differences. First of them, it uses light or infrared light rather than using the ultrasonic waves. The light or the infrared light has a shorter wavelength and it's more capable of giving better resolution. However, it is less invasive than the ultrasonic waves. This is why it can pass only through the transparent media of the eye and give the scan of the retina or the optic nerve. The second difference that it uses the principle of the coherence of the light. That's to say, if we have a light source here, it's producing the light. The light will pass through a beam splitter. Some of the light will pass to the eye, and some of the light will pass to a reference mirror and become reflected. The light reflected from the eye and this one reflected from the mirror will come together to the detector. If they both wavelengths of the lights are in phase, you know that the light is goes as a trough and a crescent. If they are in phase together, this will cause amplification of the wave. And if they are not on the same step, this will cause minification of the wave. The machine is capable to detect if the wave is amplified or reduced, and if it gives like an in vivo histological section of the tissues. This is how the machine shows the scan of the macula. It can clearly delineate the different layers of the retina as if we are looking under the microscope. It's again capable of giving the details of the choroid and the choroidal vessels. Those areas with whitish reflex, the reflected light from the eye is in phase with the reflected from the reference mirror, and those dark parts, they are off phase, so the machine is capable of detecting the strength of the signal. So the study evaluated the use of this technology of using the optical coherence tomography in monitoring papilledema and detecting subtle changes in the retina in patients with idiopathic intracranial hypertension. The study was a prospective observational study. The participant had IIH, underwent OCT imaging at baseline and in the follow-up visits. The OCT parameters that were measured included the retinal nerve fiber layer thickness, ganglion cell layer thickness, and optic disc analysis. So this is the OCT scan of the optic nerve head of the nerve fiber layer. It follows the same principle. It measures the thickness of the nerve fiber layer around the optic nerve, and it gives this simple representation. If the optic nerve is swollen, like this one for example, we'll note that the thickness line is high above the normal variation. So this is the normal value of a large number of normal patients. This is the normal distribution. The machine is capable to tell if the nerve fibers are within normal limits, or if they are slightly edematous, or they are severely edematous. The key findings of the study included that the OCT detected a significant change in the retinal nerve fiber layer thickness and ganglion cell layer thickness in patients with IIH. The changes in the OCT parameters correlated with the changes in the papilledema grade and the visual field function. So they correlated with the clinical findings. The OCT was able to detect subtle changes in the retina that were not apparent on clinical examination. So regarding the nerve fiber layer thickness, there was an increased thickness observed in patients with IIH, particularly in those with more severe papilledema. Retinal nerve fiber layer thickness correlated with the papilledema grade and the visual field function. Regarding the ganglion cell layer, the thickness was reduced in patients with IIH, particularly in those with severe visual loss. So the ganglion cell layer is one of the layers of the retina. In patients with long-standing or severe papilledema, there is some loss of the ganglion cells, which ends with the secondary optic atrophy. Ganglion cell layer measurement using the OCT correlated with this. So patients with more severe optic nerve damage and papilledema had thinner ganglion cell layer. Ganglion cell layer thickness correlated with the visual field function and the papilledema grade. And finally, the optic disc analysis revealed significant change in optic disc morphology in patients with idiopathic intracranial hypertension, so they are more swollen. Changes in the morphology correlated with the papilledema grade and the visual function. The study concluded that the OCT is a valuable tool for monitoring papilledema and detecting subtle changes in the retina in patients with IIH. The OCT parameters like retinal nerve fiber layer thickness, ganglion cell layer thickness, optic nerve appearance correlated with papilledema grade and visual field function, and that the OCT may be useful for monitoring disease progression and response to treatment in patients with IIH. If we will apply that in our everyday clinical work in patients with suspected papilledema or with IIH, the ophthalmologist should request an OCT. It will document the condition, and it can be used for further follow-up later in the after treatment. In addition, the detection of the thickness of the ganglion cell layer may give an indication of the visual function of this particular patient. We mentioned earlier in the lecture that some patients with idiopathic intracranial hypertension may present without papilledema. On the contrary, some patients may have an appearance of the optic disc very similar to papilledema, but they have different condition. They don't have a rise of the intracranial pressure. It's important to understand that those patients are suffering pseudopapilledema, and we'll talk about that in the next few slides. So pseudopapilledema is the appearance of the optic disc during the fundus examination that mimics papilledema, but there is no increased intracranial pressure. It's important to diagnose that to avoid unnecessary diagnostic testing and treatment. The main causes of the pseudopapilledema include optic disc drusen, or the abbreviation is ODD, which is primarily a calcific deposit within the optic disc. We saw that in the ultrasound a few slides ago. The optic nerve head hypoplasia, which is the underdevelopment of the optic nerve head. The tilted optic disc, which is an abnormal orientation of the optic disc. So rather than the optic nerve going directly perpendicular to the globe, it goes obliquely. This is more common in patients with high myopia. In contrast, in patients with high hypermetropia or farsightedness, this can have what we call a crowded disc, giving a false appearance of the optic disc elevation. So the differentiation between the pseudopapilledema and the true papilledema is primarily the job of the ophthalmologist. The main clues will include the visual acuity, which is usually normal in pseudopapilledema but decreased in papilledema. The visual field, which is usually normal in pseudopapilledema, defects are more common with papilledema, and the optic disc appearance. The pseudopapilledema will have a lumpy, bumpy disc appearance, while the papilledema has a smooth, elevated appearance. So in pseudopapilledema, it's a bit irregular, and we'll see that in the next few slides. Again, modern investigations can help us to differentiate between the pseudopapilledema and the papilledema. It's not only the clinical sense. So we have what's called the autofluorescence. This is a test which is very similar to the fundus fluorescein angiography that we do for patients with diabetic retinopathy and retinal vein occlusion. In fundus fluorescein angiography, we inject a fluorescein dye in one of the veins, and we take photographs of that as the dye passes in the eye. In fundus autofluorescence, we take the same pictures, but without injecting a dye in the veins of the patient. Some patients may have a reflecting material in the, usually there is no reflection in the fundus autofluorescence, but there may be a reflecting material like that, which goes with the optic disc drusen. The OCT can diagnose in the abnormality there. So the nerve fiber layer is not edematous like in papilledema. However, there is a mass here which makes the appearance of this similar to those with papilledema. And again, the ultrasound, as we mentioned before, is very useful to document the presence of an optic disc drusen at the optic nerve head. So this is the appearance of the papilledema. As you can see, the disc margins are not clear at all. The optic cup is not visible at all. It's completely obliterated. The blood vessels are obliterated as they pass through the thickened nerve fiber layer. The disc is hyperemic, so there is hyperemia over the surface of the disc, and there are some peripapillary changes, some peripapillary hemorrhages, and you may find some exudates as well. The disc is very smooth. It's not lumpy, pumpy at all. This is a case of an optic disc drusen. Again, there is elevation, some elevation of the optic disc, giving the suspicion that whether this is papilledema or not, but the surface is a bit lumpy, pumpy, it's not very smooth. The blood vessels are not obliterated, they are seen passing very clearly over the disc and towards the retina. And if you use the modern techniques like the ultrasound, the OCT, the autofluorescence, this can differentiate between the two conditions. The main problem that the boy or the girl may be going for a routine examination or for a glass checkup, and the ophthalmologist may think that this is papilledema and send the patient to the neurologist, and the patient will undergo unnecessary investigation and treatment. This is a case of a crowded optic disc. This is common to occur in patients with high hypermetropia. The hypermetropic eye is in general smaller in size, so the nerve fibers tend to become more crowded at the optic disc. There is a small opening to exit the eye. The nerve fibers become very squeezed at that part, and this will make the optic cup a bit smaller and may give a bit of elevation of the nerve fiber layer. It's not a true edema, it's just a physiological phenomena in the hypermetropic eyes. So again, it's important to notice the refraction of those eyes, because if we find that they are hypermetropes, mostly they are not suffering a rise of the intracranial pressure. This is a physiological variation called the crowded optic disc. This is called optic disc hypoplasia, in which there is a failure of complete development of the optic disc, giving what we call the double ring sign. Again, the appearance is a bit abnormal, may fool some doctors that this is papilledema. Actually, it's not. It's just a hypoplastic disc, and the patient, there's no need to put him or her to diagnostic procedures and start treatment with him or her. This is a tilted optic disc. It's more common in patients with high myopia. So the one edge of the disc is dipped and the other one is elevated. The elevated edge is usually, the borders of it are not very, very sharp. So they may fool the doctor, that the ophthalmologist, I mean, that this is a bit of papilledema. No, this is not. It's just oblique insertion of the optic nerve in the globe, giving this tilted appearance. This should be differentiated. This is pseudo-papilledema and not true papilledema. Again, we emphasize the importance of the diagnosis of pseudo-papilledema to avoid unnecessary testing and treatment. Those are some useful references about the pseudo-papilledema. Another important topic that I would like to stress upon is the empty cella syndrome, because we see a lot of children and adults referred from the neurologists with the MRI telling that they have an empty cella syndrome, and they are referred for fundus examination. So in the next few slides, we will try to elaborate the relationship between the empty cella syndrome and the IIH. So the empty cella syndrome, or the ESS, is a condition in which the cella turcica appears empty due to herniation of the arachnoid membranes, like this part. Studies have shown a significant association between the ESS and IIH, with reported prevalence of 10 to 70%. But notice that it's not 100%. So many of the patients with empty cella syndrome, they do not necessarily have an IIH. The possible mechanism of the ESS is the increased intracranial pressure in the IIH, leading to herniation of the arachnoid membrane into the cella turcica. This is a T2 weighted MRI image. ESS is primarily a radiological finding, an MRI finding that include flattening of the pituitary gland, herniation of the arachnoid membrane into the cella turcica, and CS is signal intensity within the cella turcica. We need to know that patients with ESS should be evaluated for IIH, especially if they present with symptoms such as headaches, visual disturbance, or papilledema. On the other hand, not every patient with ESS should necessarily have IIH. It's a good practice to refer patients with ESS to ophthalmology to check the fundus and see if they have papilledema or not. This will be easier and less invasive rather than sending them to have a CSF opening pressure. Those are some useful references about the condition. And the end of this lecture. I hope you liked it and learned something new from it. Thank you.